One, we are at a phase we're nearly there. So we have had an insight and detailed informative sessions on many topics. And now we are at a stage where we all should be ready to go ahead and practice. So when you get to that stage, you need to have some important thing, of which opioids are the cornerstone to pain management. And when you're going to see patients, that is one of the essential things. So to enlighten us on that, we have an eminent person today. A warm welcome to Dr. Savita Butola, who is a Chief Medical Officer at the commandant level for the Border Security Force in Tripura. She has obtained her medical qualifications from Amritsar and the further specialization qualifications from Cardiff University. And not only palliative care, she's obtained other degrees in health and hospital administration and also PG diploma in maternal and child health. And she is working as a tutor in various organizations. And she is also a national faculty for the palliative care. And she's done extensive work with her publications too. And also she's launched the first online bereavement support website in India, which is very essential. Palliative care continues on until bereavement also, which we have all known through our sessions. So a warm welcome to you, and the floor is yours to enlighten us on opioid availability.
Thank you. Thank you, Dr. Radha, and welcome to all the participants. I hope I'm clearly audible.
Yes.
Okay. If I am not, please let me know, because the internet is a huge connection here. I'm in a very remote area, and I'll switch off my camera in a while so that the voice is better. So without wasting much time, I'll go on to my presentation for the day. So are the slides visible now?
Yes.
Okay. So dear friends, we'll be talking about the availability of opioids, why it's important, and the process that you need to follow in order to get the opioids into your institutions. We have all been taught the importance of pain management, and it's important because 2/3 of the advanced cancer patients, but also a large number of patients who have HIV, almost 80% of those who are hospitalized with AIDS, almost half of the CHF patients, they have moderate to severe pain. And it affects not only their physical functioning and social interaction, it also leads to existential distress. It affects their families and communities. It increases the risk of suicide and is a miserable existence for the patient as well as for the family. But it's a very sad fact that throughout the world, the pain remains not only unrecognized, but incompletely assessed and therefore undertreated. And in India, it's worse than the rest of the world, where the less than 4% are able to get adequate relief. And though 85% of the pain is due to the disease itself, but 15%, almost 15% is because of the treatment that we are giving. And in palliative care, it's important because it forms an entry point for patients. Most of our patients come for pain relief. And there are studies to show that we are not very good at assessing pain. Oncology fellows fail to appreciate severity of pain in 73% of patients in a study by Crossman. And these numbers are not able to convey, any numbers of studies are not able to convey the personal tragedy that affects each person and their family. There was another study in India that was done in 4 major cancer hospitals in 2012 and 13, and found that out of 1,600 patients, out of 88% of those having pain, after consultation, 67% had not received or got inadequate analgesics. So we must always remember that the way we are taught, it's just like we all carry this in our minds that, oh, pain, though it is a part of the disease, so the patient has to bear it. And though opioids have been in our national list of essential medicines since 2003, the access is really, really miserable. And pain relief internationally has been declared a fundamental human right. And for patients who are suffering, the pain which is caused by, say, a police organization trying to get a confession from a patient by torturing the person is no different from the pain that is caused by a disease. And if we are not able to give our patients good pain relief because they don't have access to medication, it is just as bad as torturing somebody. And another sad fact is that six rich countries of the world, Australia, Britain, Canada, France, USA, and Germany, they consume 80% of the legal opioids, whereas the poorer nations, developing countries, which have 80% of the suffering population, they consume only 6%. And India is the largest legal producer of morphine in the world. And though morphine has also been on the list of essential medicines from WHO since 1985, the domestic consumption in India remains very little in spite of the huge burden of patients that we have, because most of it is exported. We are not taught pain relief at the undergraduate level. We are not taught about palliative medicine at the undergraduate level. And we have whatever knowledge we have about opioids when we come out of MBBS is what we are taught in pharmacology as related to addiction. I was taught morphine only in relation to addiction in my third year. So fears of abuse, fears of addiction, and along with that, the 1984 NDPS Act that came in was a really, really stringent act, and the regulations were such that it prevented its use in almost 2 generations of doctors. UN in 2005 had passed a resolution saying that medical use of opioids is indispensable for the relief of pain and suffering of patients, and that it should be available at all times in adequate amount and appropriate dosage forms for relief of severe pain. And any country having a low national consumption of opioids is a matter of great concern. Now, as Indians, how concerned should we be about that? This is a figure which shows the global consumption of morphine per capita, and this was given by Pain and Policy Studies Group of the University of Wisconsin and WHO in 2005. If you look at this, you can find that Austria, US, UK are here on the graph, and followed by Japan, Brazil, South Africa. And here you have to really look hard to find India, and India is somewhere here at the bottom of the graph. This is another figure by the INCB, International Narcotics Control Bureau, that was given in 2009. And they found that the number of patients who died with moderate to severe pain in 2009 in India, out of this, 80% of cancer patients required morphine and 50% of HIV patients required morphine. The amount that they needed in the last 3 months was roughly 679 milligram %, whereas the actual per capita availability or use was 0.4%. So you can imagine the amount of unrelieved pain that our patients have to bear. What are the barriers? I told you that almost 2 generations of doctors have grown up without learning about the use of morphine in the OPD. We have seen morphine at the most in the ICU or the CCU, and there has been tipping of balance towards cure, which has relegated care of the patient and pain relief. Too much emphasis on diagnosis, too much of emphasis on curing the patient, too much of glamorization of ICUs and medical deaths. As a result, symptom control or prognostication has been put in the backyard, and huge amount of strict regulation, severe penalties, no stocking of morphine for students to learn working it with. It has not been accessible for training, and as I told you, fears of addiction. Also, the rules under the old NDPS Act, they prevented the interstate movement, and there was no uniformity among the rules in the different states. Were involved, like excise and drug controller, were not aware, and there was a huge amount of resistance to incorporating the term medical and scientific use as far as narcotics are concerned. A lot of follow-up was needed, and the cost. The international bodies say that it is obligatory, WHO says it is obligatory to provide morphine in adequate form and doses. But the pharma companies, if you look at this list of the prices of drugs, morphine is not expensive. There's a cheap drug. Whereas if you look at the price of tramadol, or you look at the price of fentanyl transdermal patches or buprenorphine, 3 patches cost almost 1,500 rupees. And though they are governed by the same rules, NDPS Act is the same for fentanyl transdermal, you will find it in all cancer hospitals, you will find it in all big tertiary care centers, but you will not find the cheap oral morphine, because the pharma companies do not find it profitable, as the demand is not enough. And there is also the tendency of promotion of expensive formulations at the cost of the cheaper formulations, which do not make so much of profit for the pharma companies. Patients are allowed supply for a few days only. They have to undertake long journeys. I have seen patients in AIIMS, Department of Palliative Medicine, coming all the way from Sikkim, Bihar, Arunachal, just to get 3 weeks of medication. And it's very difficult for sick patients to be traveling all the way. The doctors are busy. They have to stand in line sometimes from 5 a.m., get the prescription written. And if something goes wrong on the prescription, then they stand in line all over again. The pharma person will send them back, the pharmacist will send them back, and they have to stand in line all over again and get it written. But there are studies that show that long-term use of opioids is very safe. There is no diversion. There was one study done at AIIMS with almost 12,000 patients. And there was another study which was done by Dr. Raj Gopal and David Joranson in Kozhikode in 2001. It studied patients in OPD and home care, and over 2 years, they did not find any instances of misuse or diversion. So as a lot of civil society people, palliative care people, they took interest in getting the reforms done. So NDPS Act was modified in 2015, and the procedures became simpler. The hurdles were reduced, and a group of drugs called essential narcotic drugs were notified under this act. This rule is now applicable all across the country. This is very important for us to understand, because if you actually go to the drug controller office in different states, if they are not aware, they will tell you, okay, we are still following the old rules. You have to get the permit, you have to get the transport license, you have to get a license from excise department. This is no longer valid, they tell you, because they're not aware. At present, only one agency, that is the state drug controller or the food and drug administrator, is the only agency which is involved in giving you permission to stock morphine. It allows the institution to be recognized to stock and dispense essential narcotic drugs for a period of 3 years. And we no longer require multiple agents, multiple licenses. Earlier, we needed a license to stock, a license to transport, interstate permits. All of that is no longer required. I will tell you now some definitions under the NDPS Act. Essential narcotic drugs are 6 drugs which have been declared necessary for pain management and approved by the Drug Controller General of India. These include morphine, methadone, codeine, hydrocodone, oxycodone, and fentanyl. Out of these, at present, we have only morphine, methadone, codeine, and fentanyl in India. Then, what is a recognized medical institution? A recognized medical institution is any hospital, dispensary, clinic, or institution which offers services, as you can see here in the slide, related to treatment, diagnosis, injury, deformity, abnormality, which is either maintained by municipal corporation, by the government of India, a Zilla Parishad, or any person or body of person. So literally any hospital can be recognized for the purpose of opioids being stocked and given. Government hospitals are automatically deemed RMIs, provided they have trained personnel. So I will come to that in the next slide. An RMI, what does it require? It requires staff which is trained. Any healthcare facility can purchase, store and dispense oral morphine, but they should have an officer, a medical officer who is trained. They should have a facility for safe storage, secure facility to stock opioids, and a double locking system. A double locking system means a cupboard, a locked cupboard in a locked room. It's just as simple as that. It does not require, some people think it requires 2 locks on one cupboard like you have in a bank locker. It's not that. It just means a locked cupboard in a locked room. Basic infrastructure for the staff to be able to handle those things, to be able to stock it safely, and to manage the patient. So when you apply, you need to send an application with the training certificates of the doctors and the details of the staff who is going to handle it. Then you need to have different registers. We will come to that later. So you need to document all of that properly. Who is a registered medical practitioner under the Act? Who can stock, who can be in charge of this? Any person who is either MBBS or BDS, either registered as a doctor or a dentist, and who has been trained under the the present rules, who has undergone training in the medical use of essential narcotic drugs. What is the process of recognizing an institution as an RMI? First of all is you should have a trained person, training in the medical use. After your staff or your doctor has been trained, you need to send an application to the drug controller of the state. They will peruse your application. They might send somebody for inspection, or they might just approve it. After which the institution is authorized as an RMI. Then you can see the list of approved manufacturers. You can send your requisition, purchase them. They will give you a receipt to sign. You keep one copy, send the other copy back, and then have proper documentation of the stock, of the dispensing process, file an annual return, and also renew your status after 3 years. This is the basic process. We will take it one by one. Step 1 for stocking opioids is getting a doctor trained, a doctor or a person who is BDS. After that, you send an application. I have mentioned all the forms that are required here in the slides, because you can go back to this PPT when you actually need to apply, and you can see which forms are required. So this application is sent in the format of Form 3F, addressed to State Drug Controller by the authority in charge of the institution. Now, if you work in a hospital, the medical superintendent of the hospital is supposed to sign the application. Everything that we do in a hospital or the store in charge does is on behalf of the MS. So this application has to be signed by the MS. So you also need to make your MS and your administration aware of the process and make them understand, because the moment you ask them to sign an application, and if they're not aware, the MS is going to jump. He'll say, I'm not going to sign an application for morphine or opioids in the hospital, if he doesn't understand the process. Along with that, you have to send details of the doctor who has been trained. This includes a copy of the degree, the registration, the training certificate in palliative care, the filled forms 3F, another form called 3J, where you make an annual estimate of the ENDs required. Now, you may have to calculate depending on the number of cancer patients, depending on the number of HIV patients, depending on the number of deaths that you have had in the last 3 years. So there is a formula for calculation, and you need to calculate how much of morphine you are going to need. So maybe you need 5,000, a smaller hospital may need only 1,000, and a bigger tertiary care center may need 20,000. So you calculate according to your requirement and send it along with a covering letter saying that we are this hospital and we are looking after these patients. We need so much of opioids for their care. Along with that, you have to send a self-addressed stamp envelope with stamps worth ₹27. Now this is a mystery figure. I have no clue why it is rupees 27, but the law says it is 27. So please send stamps worth rupees 27. After that, when it goes to the drug controller, they will peruse your documents and they might send somebody to inspect your hospital. Once they are satisfied, they will send a letter saying that they recognize your institution as an RMI. This reply from the state drug controller should come within 2 months of receipt of your application. They will do this in the format of Form 3G and they will allot you a certain quantity. So it is possible that you ask for 10,000 and they give you permission for 5,000. We have to follow that. If RMI status is denied to your institution, then they also have to give a reason within 60 days. Now, the important thing is the quantity that they are specifying. Supposing they allow you to stock 5,000 tablets. This is 5,000 tablets at one time within the year. If your 5,000 tablets are finished in 6 months, you may apply again. So this is the stock that you can hold at one period of time. So at any given time, it cannot be more than 5,000. But you can keep applying and get it again if your stock is used up. The fourth step is order of purchase of opioids. Once you have got your RMI status, you can write to the pharmaceutical agency of your choice. There are a number of companies that manufacture opioids and the list is given in the state drug controller website. You can check it. Also on the the NCB site, National Narcotics Control Bureau of India website, they have a list of manufacturers. IAPC, Indian Association of Palliative Care, also lists the manufacturers who are approved by the Government of India. Some of the good companies would include Cipla, Verve, Morphine, Russon, Modi Mandi Pharma. So there are quite a few companies, and IAPC has written to the Government of India that please allow the government GMST. If there are any government doctors here, they would know that we as government doctors are supposed to procure our medicine stores from the Government Medical Store Depot, GMST. So we have taken up the cause with them that you please include opioids in GMST so that it is easy for us to buy directly from GMST. Once you order, the company will send you the medication. They will send the consignment with a Form 3C with the details of the consignment so that you sign that. Original is kept with the institution and the copy is returned to the supplier. Documentation is very important for all stores, but more so in the case of opioids. And people are sometimes very scared of maintaining records of opioids, but I don't know why it is so, because in my experience, I don't know about other institutions, but we in BSF are very particular even about 1 tablet of Crocin. So if I have to take 2 tablets of Crocin and 2 tablets of Acelog for myself, I have to give a slip and they have to put it down on the register. So we don't see any difference in maintaining records for paracetamol, Acelog, Digene. It's not different from what we do for opioids. All records have to be entered. Patient's details have to be entered and all records are maintained for 2 years. Daily record of the opioids, whatever is issued to the patient, you have to put down the details for each patient. So if there is a large number of patients, you can have separate records for your store and dispensary. But for us, like we are a very small hospital here in the periphery and we have very few patients. So what we do is we have only one register where we have the stock and we directly issue from that register with the details of the patient. So separate record of every patient has to be done in the format of Form 3E. I'm going to give you all these forms to take a look, keep them with you, keep this PPT with you. Whenever you need to make your administration or your store in charge aware of the procedure, please use them. Then you have to keep a record of all consignments and file a return. This is important. File a return for calendar year on the 31st of March in the Form 3I to the Drug Controller of State. Now, I I know it's a little confusing and you will not remember whatever I have told you, but I have put it down in the slides. Please go back to it whenever there is a confusion. What about individual practitioners? Not all of us are not working in institutions. We may have clinics, standalone clinics. So the new act allows them to stop opioids for their practice also. Any RMP may hold a small stock of ENDs for emergency use in their own practice without any special authorization, but this should not exceed the amount which is given. So for morphine, it cannot be more than 500 milligrams. For codeine, not more than 2000 mg. Similarly, for fentanyl, 2 transdermal patches of 12.5 or 1 patch of 25 micrograms. If you need more than this limit, then you have to apply using Form 3B to the state drug controller and receive a permission for a period of 3 years. It's important that we make our purchases only from authorized dealers, authorized chemists. Chemists who deal with opioids need to have a narcotics license. And this list of dealers should ideally be available with the state narcotic commissioner. And ENDs should be prescribed only to selected patients. Now, this is important for us as doctors. Indiscriminate use leads to complications, as we are aware. And you must have read about the opioid misuse in America, the huge amount of problems that patients are facing there because of overuse. Please be very cautious when you are using them for chronic pain, non-malignant pain. So what I see in my practice is a lot of tramadol being used by orthopedicians for backache, and the patient goes unsupervised. It's not that we cannot use. Any severe pain may require opioids. The only thing is to be sure that it is under supervision, and patient has one person from where he's getting the medication and is properly tapered off. If you do not taper off medication, patients can have physical dependence in as little as 5 days. 5 days of backache, patient getting tramadol, patient may develop symptoms if you are withdrawing. Be very sure that you are tapering it off like steroids. Then there is another rule that ENDs cannot be transferred, loaned, or sold to other institutions except with the use of the state drug controller. Like in Gwalior, when I was posted in Gwalior, my hospital had 5,000 tablets of morphine and I got posted out to Tripura. So at that point, they did not have a trained palliative care doctor who could prescribe those tablets left. We had almost 2,000 tablets left and nobody knew what to do with them. So somebody suggested that we can give it to Regional Cancer Center at Gwalior. But we couldn't do that because of this particular rule. So what we did was we requested them to send patients to us. We requested that you please send your patients who need opioids to us directly so that we can dispense it to them in our records. Then another thing is, hear you. Pardon? Did I miss out on something? Were you saying something to me? No, I think
there was someone unmuted by mistake.
Okay.
You may continue.
Okay, fine. So unused END, supposing the patient expires or patient may have good pain relief after surgery and may not require opioids, then what is to be done with those opioids with the patient? Patients can give the opioids back to the institutions and they can note down the batch number, note down the details and take them back into the store as fresh receipts. If by chance there is any quantity which expires, that it has to be destroyed in the presence of officials from the state drug controller. So please try to ensure that these are precious drugs and they should not go waste. If you have some stock left, please make sure that some patient uses it. And if there is any change in the RMP, that is the recognized medical practitioner in your institution, the doctor gets posted out, resigns, leaves, or goes transferred to another place, that change has to be intimated to the state drug controller within 7 days. And whoever is employed in their place, the details of that doctor have to be sent.
Dr. Savita, sorry to interrupt. I believe a couple of participants have said that your voice is breaking.
Yeah, saying what?
Your voice was breaking.
My voice is breaking.
Yes.
Was
Was.
breaking.
So what I can do is I'll switch off my video and probably that will help.
Yes, ma'am.
Okay. So I wanted to show you a prescription, but I think I'll show it later on. I was not able to find it at that time, but what I wanted you to know was that there is a proper format called DD12. In case your institution doesn't have a stock of morphine at any point, you can use that form for prescribing morphine, but it has to be given in triplicate and it has to be given to a chemist who has a narcotic license so that the patient may be able to buy those drugs if they're not available in the institution. So this was a paper which was published by All India Institute Delhi, and it talks about the circle of safety when we are prescribing opioids. First thing is that you have to have trust with the patient. The patient has to have trust with the team. Awareness of not only the patient but the family, the hospital administration, public at large, people who are involved with the policies, and the law enforcing agencies. All of them in the community need to be aware about the use and the processes involved with opioids. We need to empower our staff, the doctors and nurses, so that patients have good access. We have to prescribe responsibly, make sure that patients are able to access. It is very frustrating if we train doctors for pain relief and they do not have access to the morphine in their institutions. We need to educate the community and society as a whole and make sure that there is safe dispensing. The processes which are prescribed have to be followed properly. The patients have to be supervised, and total pain relief. That means that do not depend only on opioids. There are some pains which do not respond to opioids, and patient may have psychosocial, emotional, financial issues which are aggravating the pain. Patient may keep on complaining of pain again and again, even with opioids. Just don't keep increasing the dose. And last but not the least, the step 4 of the WHO ladder, which talks about interventions. So even if we are ourselves not able to give interventional pain management to the patients, we must be aware of where these things are available and where we can refer the patient. So strong opioids, they exist to be used, not just to be withheld. And even after all these new drugs have come in, morphine like aspirin and digoxin, which have been used for almost 100 years, it remains a safe, effective, cheap drug. It remains the gold standard for management of severe pain. And we must use opioids according to the severity of pain in the patient, not the stage of the disease. Please remember, early stage disease may also cause severe pain in some patients. And it's very, very important for us to remember that normal release morphine has to be made available in our institutions before we go on to fentanyl or other expensive formulations. Can you do at your end besides prescribing for the patient? Help increase awareness for your colleagues, for patients, the general public, the policymakers, and as I said, law enforcement agencies and police organizations need to know about it. It must be integrated into the existing care at all levels. So whether you're in gynae, whether you're in ENT, whether you're a pediatrician, in ortho, whether you're a general practitioner or a nurse practitioner, all of you can utilize the palliative care approach for better holistic care of your patients. Networking with other colleagues is very important. Networking with other people and other organizations providing palliative care throughout the country is very important, because we cannot do everything ourselves, and most of our patients come from rural areas. Sometimes we need to refer them back to their homes for terminal care, and then whoever is the nearest person to provide care, you need to know. These information you can get from Pallium India website as well as website of the Indian Association of Palliative Care, which lists them state-wise. Education and training, especially of undergraduates, is important. And last but not the least, we need a lot of evidence for India and for Indian setup. So please go ahead. There are lots and lots of research topics within your own area of work. Try to build up the evidence for our own patients and get it published. And the last thing that I would like to tell you is that when we do palliative care, when we try to provide good end-of-life care training for staff and for doctors, it is something that we are doing for ourselves, because all of us are going to go down that road, and all of us are going to die in the system that we helped to create today. So ensuring good pain relief, ensuring good end-of-life care in all our institutions is ultimately something that is going to help us, our families, our communities. Thank you very much. And now we can take questions.
Thank you very, very much, Dr. Savita. Many important things, as you have mentioned, awareness. And next, I would say, so everyone has to use it and see to know the benefit. And especially like, for example, I would say pancreatic malignancies, they are in agony, and many are scared. But once you start them on morphine and see the difference, if each one has the opportunity to see one patient get the relief, then they will put all the effort to get the morphine and use it. Like, as we say, it's that much is needed. And then I think this availability, I was reading some WHO information also. World over, morphine is available, but it reaching the patient is still a challenge in many developed countries. Not only developed countries, they say, many places they are aware and available, but getting it to the patient is still a challenge. That is what I think 2020 or information was that which I had obtained and for some paper or presentation, and that is what it said. So it is from that point of view, I think we have to work hard towards it. Even in many parts of South India also, it's not available. Bigger cities seem to have it, but smaller places still don't have, even though the need and demand is there. So it should be a collective effort, I would say, for everyone to, and you have given us clear guidance on how to go about it. So really informative presentation. And normally we would leave it like people can unmute and ask or type in the chat box. Let me have a look in the chat box if anything. No, so I would say it's open like for everyone, because this is something everyone would love to know. Please go ahead.
Ma'am, I have a question. If you have training in palliative care, like we are registered and we can prescribe morphine. What about trainings in, if you are a graduate, postgraduate in anesthesia or something like that, do you still require a palliative care certificate?
Yes. Yes, you would need, because in anesthesia, you may be aware of the use of opioids in other situations, but for stocking and dispensing in your institution, see, this, what we were talking about was about stocking in institution and dispensing it from your pharmacy, from your dispensary. For that, you need to have training in palliative care. Now, it does not specify how much training is required. The NGOs and the organizations which are involved in training, we all want it to be at least 10 days practical training. But there are state governments which are accepting 3 days training. State governments usually do 3 days training, but we feel it is not enough. So we are still working on getting that 10 days clause inserted into the rules. But yes, for anesthesia people also, you need to have palliative training. It's different.
Oh.
See, because just one thing in that is, from anesthesia point of view, basically I'm also an anesthetist. That's why I'm trying to say anesthetist. See, we know the use of it in acute cases, and we do, and I am a chronic pain physician too. So with all that, I have used it in all fields. But generally, if someone is an exclusive anesthetist, an intensivist, long drawn practice and long drawn use, for that point of view, and especially stocking and dispensing, main thing is documentation. Okay. And that is very, very important. That is to save ourselves too, and do justice and a clean ethical practice. Okay. So every word counts in it. So from that point of view, these requirements are there. I think in our previous session, we did mention you have to obtain basically a palliative, you attend a course or something. And that also, there are specifications in that. You have to attend the course and also do, I think last time in the management session, we had information on doing, we heard in that, we were told that 5-day program. So before, as I was aware, it was a 10-day requirement was there. But recently our HR person said that there are institutions who are doing 5-day programs. And that could be a state, individual state might have different requirements. So that is essential, because to follow all these rules and for your safety, especially I would say that is in the best interest of the doctor also. So that when you have to have it and do it, you have to make sure you are doing it properly and you are not in trouble anytime. So putting all that into perspective, it is essential to do it.
Also because, there is when practically you work on the ground, in the institutions, there are people who are doing different parts of the work. So there may be somebody who is in charge of the store and procurement, and the departments themselves, the ones who are doing clinical work, are entirely different. So you may be in anesthesia without being aware of the procedures which are involved in the purchase and stocking of medication. Recently, we did a survey on opioid availability by IAPC, and we found that there was a total, divergence. People who are actually prescribing have no clue of what goes on in the purchase of stores and how that process occurs. What is the administration doing? And administration has no clue about why it is important, why these are required. So sometimes the MS will not sign the papers, sometimes the store in charge will not cooperate with you. So unless and until you understand that whole process, you will not be able to actually get the thing into the institution. And also to supervise the staff. Because see, the act requires that the doctor who is in charge, who has been trained, your name will go in the documents. And you are the person who are going to supervise the staff. So whether the staff is doing the documentation properly is something you will be able to do only when you are handling the stores yourself. So that may or may not be part of the anesthesia training.
Definitely true. The staff only, because I've seen it, the staff will do. And see, you can't you can see patients and do things. You cannot see patients, dispense the morphine and then write register. It is practically impossible. So there is some hand-in-hand work is needed. So the staff also has to understand the seriousness and importance of it. Otherwise, see, if something goes wrong, it will be a very unhappy experience. So better it is done in the right way.
Sometimes they can miss out on very important things, like when we are when we are dispensing to individual patients, this requires that we give the number of the patient, the registration number in the hospital, the Aadhaar number of the patient, the diagnosis, the contact details of the patient, the address, the phone number. So sometimes if the attendant is coming, it is okay. It allows us to give the morphine to the attendant if the patient is bedridden. But practically what we do is we see the patient on video. That is what we were doing during COVID also. We would make sure the patient is alive and well. We are dispensing it to the patient without seeing. So how do you make sure the patient is alive when you are giving the morphine? Check on video, give it, see, write the name of the attendant. Ask the attendant to always carry their iCard with them when they come to collect morphine. These are small details which are practically important. Sometimes I would send patients from Jalandhar. The attendant would go from Jalandhar all the way to Chandigarh, 5 hours away, to buy morphine from the authorized dealer, and they would forget to get their iCard. They wouldn't get it. So they have to go all the way back to their village, collect the iCard, go the next day, travel again, get the iCard, show it down and write it down, and then bring the morphine. So little things, if you guide them that, see, even if you're going as an attendant, you need your iCard. It will prevent them from spending 2 hours of travel and the money and losing out on their 2 days of employment. And our staff would sometimes forget to take the signature. During COVID, everybody was busy. Our hospital was declared a COVID hospital. And this was only a side thing that they were doing palliative dispensing of morphine, but everybody was so occupied with other work. 3 patients they dispensed without taking the attendance signature. So unless and until I, as a supervisor, know the importance of the signature of either the attendant or the patient who is receiving the drugs, I'm going to be in thick soup if somebody comes and checks my documents. So that's what Madam is also saying.
See, exactly. I've had these experience. So what I used to tell them was, don't mistake me that I'm very strict or anything. If I have to be strict to save you and me. So once you explain exactly what she said has happened, they'll come, and even though in good interest, all empathy, sympathy is there, but in the documentation and things, that will not help you. And next thing is that, for example, she in our talk, she did mention that one small thing will not be there. You have to go back. Yes. Why? Because there are strict rules how these prescriptions have to be done. Name, number, everything has to be mentioned, because when you're documenting in that register, you have to write how much, like, for example, I'm telling 200 is the number, 20 you give. You have to write 200, 20 given, 180. It has to go in that order. If one step you miss, it'll be, see, you may think, oh, what, that is what it is. Okay. If it is done that way, it is good for you and the patient. And because for that way, from that point of view, you have to train the staff. See, you can't be seeing patient doing that. And then if this 220, 180 is not documented properly, then you will be in trouble.
I'll give you another example. You know what happened once was, this is not about opioids, but this is just about how we can make mistakes when we are overworked. So I was in the ward, and I had written, I wanted to write dispersible tablets Cefixime 100 mg for a pediatric patient, and I wrote injection Cefixime. And we had a very hostile newcomer in our staff, this doctor, who comes and tells me, Madam, what is injection Cefixime? And for 2 minutes, I was like, what have I written? So somebody who wants to catch hold of your mistake somewhere, and in India, we are all aware of the red tape that we have. People are not kind to you if you make mistakes. They will not think that you've been sitting at the patient's bedside for 48 hours, not eaten, losing out on your sleep, and you are liable to make a mistake. Nobody's going to excuse you for that.
Nowhere. So we used to be taught, you have to learn to save your skin.
Yes.
Okay. That is nothing wrong. See, these things are there in any field and any specialty. So like every day, if you have some discipline, it will not be difficult at all. Everything you follow step by step. The same thing like in computer or whatever you take, there's an algorithm. So that's why there are guidelines. You always stick to them. And then it will be fine. And that is why it is better to know how it has to be done. Once you know it the right way, you can never go wrong. So all these examples, why both of us are trying to tell you is that not to scare you. Main thing is, oh, it has to be done this way and let me use it. That's what. See, the main problem with this is the myth and things which puts off people. So you all, I've used it in many ways. So I know the benefit of it, and I will try level best convincing people. And then once they start seeing the benefit, everyone uses it. And I've had very good experiences of people who were literally not able to do anything, to a state where, oh, I could do what I was used to doing. And they, even at the end of their life, they have not had any difficulty. They were doing what they were doing. So that much of benefit, what that patient experiences, is what gives satisfaction. And that is why you're doing your duty. You're not doing anything more. To do your duty properly, you need to know things properly. So it is possible, and let us all try to do it in the right way so that you are also not affected by it. Anything else? Because see, this is something, a practical session. What is that you would like to clarify or something? And another thing, what I liked was in your presentation, you have given everything. As and when they need it, they can go back to it. So that is what, see, now they may all have many ideas and things, or when they start using it, which form, what should I do? There, your presentation will be very, very handy. A big thank you for that.
And we keep telling that to all the participants that when you actually start working, you will face problems. And please go back to your mentors in Pallium India, go back to people. There are people who are going to help you out with that. There is a network of associations. So please find your nearest senior person and approach them for help if you find problem in accessing morphine. If there are no more questions, then
Madam.
Exactly. That we are also coming to that. We'll just, does anyone, I heard something, there's nothing in the chat box. I've just checked.
Madam, is the FCPM course inadequate for morphine procurement, or we should go for a direct 10-day session? For
Yes,
morphine
you need the direct session. 5-day, 10-day depends on which area you use. You attended the management session, am I right?
Yes, madam.
So in that, she said there is a link which tells you, depending on the state where you are, it will give you how many days in-house you need to do.
Okay,
So for that, Sri Priya, if you have any queries, you can get in touch with Sri Priya, and then she will get in touch with Aarti Venukumar and get in touch with you. Depending on the region, we have got 4 regional heads. So that is not an issue at all. Depending on your area, whether it will be a 5-day or a 10-day, it will matter. And every detail will come in that. You do the 5 or 10-day one, there is a number of cases which you have to do and submit. And once you combine that with this certification course and that in-house, then you are eligible. Is that clear for you?
Thank you, ma'am.
Welcome. See, Pallium India, all of you have got, see, everyone may say, oh, I don't have someone to tell me. So all those queries or questions, no one can say anymore. You've got full details with, like Aarti gave us, that or like website, you go in and see. On top of that, don't hesitate to get in touch either with Pallium or with one of us. See, if I don't know something, at least I will get in touch with someone who will be helpful to you. We are all there to help each other. Okay, so that is the way to move forward. Exactly the same thing only Dr. Savita also told us today. At least you've got willing people to help. So don't worry. Please ask.
And one practical thing, I'm sorry, I just wanted to tell them one very important practical thing is, before you try to stock, see, there are states where the concept of palliative care is very new and people are not aware. So try to organize a CME within your hospital staff so that your administration is already aware when you send up your application, when you start your paperwork. Otherwise, they'll spend at least 3 months questioning you why this is important, why you want 5,000 tablets, you don't have cancer patients, why you want to start palliative care. You can always refer to the nearest medical college. Why are you wanting to put your neck in? Then when you send your application, it's good to pay a visit to the state drug controller office, or to at least give them a call and tell them, that's it, this is what we want to do in our hospital. We are sending an application. Please do it. And then keep following it up every 15 days, because unless you push it, they will forget. So these 2 things, before you put in your application, try to do the homework and groundwork with them beforehand. It always helps.
Very, very useful. Because if you're going to be in the wrong books of the medical superintendent or the in charge, you're not going to be successful. You want to do something, and then some being pushed down in your morale won't help you. You want to do something. So make sure that morale will not be affected. So that's what we say. You have any issues, go with solutions. That is a better way forward. Okay, so what awareness, and if once you raise awareness, one more person may come and help you. They'll say, oh, I'm also willing to come. Let's do. So you may get another helping hand. You don't know what will be there. Something beneficial could be there. So always make sure that you will get it ticked off rather than having obstructions or obstacles. Okay, Sri Priya, if everyone
Can
is
I ask
happy and there's
one
no
more
other
question, madam?
burning query, go ahead.
Madam,
As
one more question, madam.
ahead.
Madam, as madam said, an individual practitioner can also store morphine. So is it like a clinic, means like you should be in a clinic, or if someone is practicing at their home, so will they be able to store morphine as per the regulations?
it says a clinic, but I don't know. I've never faced that question before. What about you, doctor?
See, exactly. Individual clinic, I am also not aware. But see, in that you saw, you have to go through the same drug controller or for your area and find out. See, 500 milligram will be 50 tablets. Am I right?
Yeah.
That's what your
10 mg,
presentation
50
said.
tablets. Yes.
Huh? 10 milligram, 50 tablets. Because 10 milligram tablets is what we do. Normally it comes as 200 tablets in a box. I have worked like for more than 2 years in Adair Cancer Institute also. So that with that information I'm telling. So if from that presentation what I saw, 50 tablets is what you can have maximum. 10 milligram tablets. So see, from that point of view, I have also not had, because I have seen many institutions have it. Individual person having it, I have no experience with that, but it may be possible, because when it is there, you should only find out. See, that means it's an individual practitioner, isn't it? So once you obtain the certification course and the in-house training, and then you're at that stage, maybe you will have to talk to your local area drug controller doctor, that with all this information, will that be possible? Where do you live or practice?
Possible, but the thing is, your clinic has to be registered. If you have this hospital or your whatever, the clinic is registered at that particular address, then I'm sure it allows. But
Exactly.
better to be safe and better to send them a letter of intimation at least.
Okay.
And as she said, your clinic or whatever it is has to be a registered one. Because see, if it's you're practicing at home means some commercial, see, even if you're practicing at home, your that would be considered as a commercial, like for example, I'm telling you, your electricity or something for that area, you will be paying commercial amount. That is how, if it is legal. Because I have had a clinic, so that with that experience, I'm telling you. So in that way, you would be registered as a commercial practice. Long back, 25, 30 years ago, I have done that. So with that information, I'm telling you. So if it is a registered one, you will be registered as, so as she mentioned, that is important. Somewhere you need documentation to show that, see, when they are approving something, they should know where it is going, from where it is coming to where it's going, and from there it's going to which patient. See, it is just tracking everything, doctor. Morphine that is what it is. These are all, these type of, they are called as controlled drugs. Okay. When you have controlled drugs, you have to have the origin, where it is, and then how it is expended. That's why you may maintain that register. If your practice is registered, you should not have. But see, you for anything and everything, always better to get it from the horse's mouth. The drug controller will be the person to confirm for you. Where do you live?
In Kerala, madam.
So then in that case, Pallium will be the best person to help you. That will be the better way forward.
Okay, thank you.
So Pallium and then Pallium drug control, what they have, getting information is not going to be difficult for you.
Okay, thank you.
Okay, Sri Priya, if I would, are we all okay? Anything else there, or else I'll pass it on to Sri Priya.
Thank you, Dr. Radha. Thank you, Dr. Savita, for joining us. In spite of that technical glitch, actually, so sorry for that, Dr. Savita, and thank you for joining us. And thank you, everyone, for joining us today. I hope that you all had an enlightening session on opioid availability, how to procure and all. So just reminding that the next is going to be our last session in the series. This is Sri Priya, along with Dr. Radha Venkatesan and Dr. Savita Butola, signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care. Bye-bye.
Thank you, one and all.